Now I think I'm going to proceed with my talk. And I know this is very fast paced, but I'm hoping that you guys get a nice, good perspective of how TCD has been used in various aspects of critical care evaluation of our acute brain injury patients. I'm going to cover in the next 12 minutes non-invasive ICP evaluation. I'm going to go ahead and share my screen. And if somebody can confirm that you can see my slides and progressing as well.
Yes.
Perfect. Okay. So, non-invasive autoregulation, non-invasive ICP has been a pretty hot topic of debate over the last few decades. I have lots of conflicts of interest with regards to TCDs. I think just like Erica said, I am a big believer of using this as a tool. By no way, I think this is a perfect tool, but I think, if you know how to use the tool, it has definitely many advantages, but I don't think we really used it very well. So when it really comes to using TCDs for non-invasive ICP assessment, I'm going to cover the physiology with regards to clinical applications, some major studies that you must know, research gaps, which I think is a whole interest of mine, and my hope is that some of these research questions excite you enough to do further work. We'll talk about some conflicts, education clinical gaps, and some future steps. So folks who have attended my lectures in the past know how passionate I am about looking at brain holistically. I firmly believe that a non-invasive tool such as point of care that has changed the paradigm of how we evaluate respiratory failure shock in the ICU is extremely underutilized when we come to cerebral hemodynamic assessment. At the end of the day, everything that we do in the neurocritical care unit or in the critical care unit with patients with neurological vulnerabilities is targeted towards preserving the brain blood flow, and keeping it from any side effects of too much electricity or chemicals. And neuroultrasound can literally measure each of these components of the brain, whether it comes to structure. You will have Dr. Lightfoot talk about B-mode ultrasound for midline shift and ICH detection. We are covering blood flow assessment using transcranial Doppler. You can also kind of see the downstream effects of seizures with TCDs. TCD is not going to replace EEG. I'm not recommending that. But combining TCDs with your electrical assessments can add to more value. And of course, autoregulation and a couple of other things also can benefit when you have that additional information of cerebral blood flow attached to you. And then TCDs is just a non-invasive way of looking at it. It can give you continuous measurements. And that's what has kind of excited people to say, why can't we use TCDs for non-invasive ICP? So the overall framework, I will focus on the use of TCDs both quantitatively and qualitatively. When it comes to qualitative assessment, you can use flow patterns and their evolution to look at TCDs. And when it comes quantitatively, people have looked at pulsatility index, which is a marker of distal cerebrovascular resistance, very sensitive but not very specific. And I will review some estimated CPP formulas that have been investigated in about 20 plus studies. And these CPP formulas are the ones that are kind of used to calculate ICP. And if you truly look at the way ICP became a target for therapy in early, Lundberg's work in 1940s and 50s, the target was to monitor and preserve brain perfusion, right? We just needed a marker, and we didn't have TCs at that time or blood flow parameters. So ICP became a way as a surrogate of CPP. So if we truly look at, we're interested in CPP, So early on, knowing that mean flow velocity and PIs were two numbers that we used pretty often, PI became a attractive number to look at with regards to distal cerebrovascular resistance, which in acutely injured patients can translate to increased ICP. And classically what happens is you've got these low resistance waveforms and they convert into high resistance waveforms. So low PI becomes high PI. This is 0.7 something. This is 1.4. And that PI increase can show that increased cerebrovascular resistance has happened in this patient, which translates to intracranial pressure. Data from Cambridge has shown continuous ICP measurements along with CPP measurements have been reflected in both flow velocity. If the patient is not autoregulating, your increase in CPP will result in a drop in flow velocity. and increase in PI. So change in PI can be a linear marker of ICP. The challenge is twofold. Number one, PI is a very sensitive marker, but not a very specific marker. If I have been smoking for 40 years, if I have had atherosclerotic disease, my baseline PI may be very high. We have normal patients with a PI of 1.7, 2.1 that have absolutely intact blood flow and are walking without any neurological deficits. So that's one challenge that we've had with PI. The second part is that focal or global pathology affects PI in a different manner. So we all know that compartmentalized brain injuries may not reflect the vascular resistance across the whole globe. So the question is, where do you measure the PI, and whether the focal injury will cause increase in global PIs with increase in ICP, the same as say a global injury. Those are the things that have not been educated. Other things that people have done is use different flow parameters. This transition of low resistance waveforms where peak flow velocity initially increases with increase in ICP to maintain perfusion. Then the diastolic flow starts dropping. So you can see how from this pattern to this pattern, diastolic flow is dropping. So people have used these transitions to calculate non-invasive CPP, where the mean flow velocity, the diastolic flow velocity, and various combinations have been used to propose formulas. The most common formula used ends up being this Schmidt formula, where MAP multiplied by the diastolic velocity divided by the mean plus 14 gives you a non-invasive CPP, and then you subtract the ICP from, subtract the patient's systemic MAP from it to calculate the ICP. There has been a black box phenomena, a critical care closing pressure phenomena. Quite a few of them have been published. But because of logistics, I will talk in a few minutes, have not quite scaled globally. The qualitative value also stands. So if you don't have the bandwidth or the clinical volumes are high, you don't have the time and the infrastructure available to make these calculations by bedside, you can look at these waveforms. These are hyperemic waveforms, normal cerebrovascular resistance, very high cerebrovascular resistance, where the patient probably has high ICPs, unless these are baseline because of atherosclerotic disease, and then oscillating waveforms, where flow during the systole is the same as flow during the diastole. And these oscillating waveforms basically means zero cerebral blood flow, no net forward flow. These qualitative waveforms at their progression have been validated in herniation, and you can use them as target. If the patient transitions from this waveform to this waveform, their ICP has gone up. In the last 2 decades, there has been considerable interest in looking at ICP measurements using TCDs, but unfortunately, only 22 studies have been published so far, with a significant heterogeneity in the technical robustness of the study itself and the quality of study itself. This was a recent scoping review published by Dr. Roba's group that looked at different formulas and different approaches that were used to compare non-invasive ICP using TCDs to a invasive model. The challenge was there was no homogeneity in the design. Some studies had intermittent continuous monitoring. Some studies had venous TCD, sagittal sinus and ophthalmic artery measurement added to it. There was no consistency in which TCD parameter they chose. One of the studies actually looked at imaging and non-imaging TCD. There was no consistency in which part of the MCA is being insulated. And proximal and distal MCA are not the same. And similarly, global versus focal injury, and whether the ICP measurements were done on the same side or the opposite side of the injury was not quite addressed. The most notable trial, in addition to a few work done by Daniel Khadim, is this trial by Rasulo. Frank basically looked at patients that were getting ICP monitors and performed TCDs before, during, and after the ICP monitoring phase, and used predictive analytics to look at the accuracy of TCD in predicting an ICP threshold of 20, 22, or 25. Despite extremely high negative predictive value, the study did not show that TCD could translate into a non-invasive surrogate replacing ICP monitors. So it's a great tool to say patient doesn't have an ICP crisis, but it's not a good tool to say what the ICP is and what those serial changes are. There was a recent global consensus led by Dr. Roba that looked at various non-invasive parameters for TBI in particular. And we basically came up with 34 questions. and looked at 4 different perspectives. One was the optic nerve sheath diameter that Dr. Hizela will be reviewing very soon, the NPI from papillometry, the TCD-based PI measurement, and the TCD-based non-invasive ICP measurement using the Schmidt formula, the same formula that Impressit used. And with this, we basically came up with consensus-based recommendations from TCD experts across the country about when to use non-invasive ICP, which values to use, and I will highly recommend you reading these very detailed recommendations. The clinical integration of non-invasive ICP when you have no ability to do invasive measurements, and made some recommendations with regards to the PI cutoffs as well as the serial changes. And the beauty of these recommendations is that it also gives you a summary analysis heat map on decision making. How likely was a particular expert, a consensus member, willing to either escalate or de-escalate treatment based on the non-invasive ICP number, just like Krebs had done in Randall Chestnut's paper. It also gives you an algorithm for multiple clinical scenarios, how to use these cutoffs to escalate treatment when you don't have a CT scan. Because the whole point of non-invasive ICP is to allow ICP measurements where typical resources are not available because of geographical austerity or because of low resources. So it gives you algorithms to escalate with and without a CT scan, how to integrate it when neuroimaging is available, and also de-escalate. So we just don't keep the high ICP management, whichever tiers you're on, it also guides you to de-escalate with and without CT scans. Despite such good work, we still have quite a few research questions. I think the B-Iconic consensus statement is a very positive step in the right direction. But the challenge is, even if you look at just TBI, we haven't even looked at ICP paradigms in subarachnoid hemorrhage, post-cardiac arrest. But even in TBI, we have quite a few goal-directed therapies, whether you look at Rosner's protocol that uses CPP targets, BTF guidelines that recommends measuring autoregulation and deciding CPP targets based on that. Lund protocol, which is kind of diametrically opposite than most of the protocols. And then obviously the ICE and Krebs protocol, which just looks at imaging clinical exam to guide ICP management. We don't even have the best level 1 evidence on which of these goals are great for goal-directed therapy. And B-Iconic obviously needs to be validated. But the challenge is we don't have a gold standard at this point. So clinical outcomes becomes the only standard. So my hope is that the next step will be validating the B-Iconic guidelines with regards to clinical outcomes. In addition to the challenges I shared about not evaluating ICPs beyond TBI, even in invasive monitors, non-invasive monitoring has such good potential in austere settings, resource-limited settings, even for advanced medical centers. We have a significant subset of patients that don't have access to invasive monitoring because of anticoagulation or because of other advanced hemodynamic support. You will hear Dr. Lucia Rivera talk about use of T-series MCS. This is just unexplored. It's like a whole planet waiting to be discovered. The other question I myself ask is, we keep on asking this question that T-series should be used in evaluating non-invasive ICP. Is that the right question to ask? The whole point of managing these patients' brain resuscitation is optimizing cerebral perfusion. We are even doing tests like the Cogitate trial that is looking at optimizing CPP for a patient based on their degree of autoregulation, calculating patient CPP opt. Is that even worth to look at an ICP number if the patient is in the CPP opt range? So that's a question I often ask myself, which has not been answered yet. The other thing I always wonder is, when I look at these waveforms, when I look at these numbers, if I have 3 patients with ICP of say 65, and I've done enough number of these patients to know that this exists, look at these 3 waveforms. The first one is an oscillating waveform with a peak flow velocity of 74, a diastolic velocity negative because the oscillating waveform with a PI of 2.8, which is pretty high. You can see this is irreversible cessation of cessation of cerebral blood flow if the underlying injury is irreversible. If another patient with the same ICP has this waveform, very high peak flow velocity, very high diastolic velocity, and very low PI, which is opposite of what you would expect. Not all high ICPs have high PIs. There are a significant amount of high ICPs that come from low PI. Compared to this patient, where the velocity is normal, whether it's end diastolic or peak flow velocity, but the PI is very low, almost relative hyperemia, but normal velocities. All three patients having the ICP of 65. These phenotypes exist. We just have not classified these phenotypes, and we have not adjusted these phenotypes in our investigations for ICP evaluation. And for anybody who's listened to my ICP talk, I always talk about this is not something that we came up with here. Experts have been talking about this for years now. Dr. Kofke put actually this together as a viewpoint that gave me this idea, which basically talks about phenotypes of ICP, perfusion limiting ICP crisis, which is how we traditionally think of ICP, that blood flow will go down, and perfusion driven ICP crisis, where the relative hyperemia is driving the blood flow. So we never really measure blood flow in our ICP crisis. We assume them or calculate the CPP. And it might be worthwhile investigating these phenotypes before we go on to non-invasive ICP measurements with TCDs. The other challenge I have is, since I teach a lot of education courses, and I also do a lot of help on protocol development for TCDs, I'm always challenged by the inconsistency in the technical robustness of our TCD protocols used in research. If you're looking at the brain, you can look at TCDs. You can look at the highways. Proximal M1, proximal ICA will give you a flow through the highway. But you can also look at the parking lot. And doing distal MCA measurements and proximal MCA measurements are very two different things. This is exactly the same patient with the risk of high ICPs, whose peak flow velocities are 69.53 with a mean of 58 and a low PI. In the proximal MCA, a little more proximal compared to distal MCA early M1, which is 45, 30, and 0.5. You can't use both the numbers, and you can't just assume that one number is better than the other. We need to investigate and prove which number is better. And the scoping review I mentioned also highlighted these deficiencies, describing how scarce the data was with regards to technical consistencies. Lastly, Dr. Sigmund talked about none of our neurocritical care, neuroanesthesia, neurology, neurosurgery programs, even in the US, have structured mandates for cerebral hemodynamic evaluation using non-invasive parameters. There have been some work done with that regard. There was a very nice consensus statement, again led by Dr. Raba, that put together consensus statements with regards to head-to-toe skills for intensivists across the board, not just neurointensivists. And the neuro part did make to it. She also led a group that looked at consensus on skill recommendations. There have been some recommendations towards credentialing and basic competencies with point of care from European Academy of Neurology, but in critical care, this has been lacking. And my real hope is that as next steps, with such a wide area of research gaps available, some of you will consider taking at least one of these little hypotheses and addressing that. And hopefully in a few years, when Dr. Raba's group hopefully decides to do another consensus expert recommendations for head-to-toe point of care ultrasound. At the brain part, you can see we did not get much traction on the clinical suspicion of ICP. I really hope that the evidence towards this is much more to consider, and also the robustness of the guidance is different. And I hope that the next round of these guidelines address the use of TCD as a screening tool to rule out and rule in edema, as a way to complement your neuroimaging and neuromodality as a target for goal-directed therapy, but also takes into consideration the context for acute brain injury, focal versus global, not just restricted to TBI, but we also start phenotyping our ICP crises rather than using one blanket ICP number for all. Thank you, guys.